Thanks, Alex. Good morning, and thank you for assigning me this exciting topic. But I'm going to try to convince you that you should start thinking about the lumbar spine, even if you're a DA surgeon. I'll tell you why. These are my disclosures. We noted the goals of total hip arthroplasty: relieve pain, restore function, optimize hip biomechanics, equalize leg lengths if possible, provide a stable joint, and optimize component position for long-term durability. Pretty straightforward. However, you've heard it from the podium for the last few years that there is no universal safe zone for everybody. Anatomy differs. Native version, offset hip center, pelvic tilt differs, pelvic deformity, and lumbopelvic mobility. And all of that is an issue. So how do we define the safe zone? If you hear from us here at the podium, there is no universal safe zone, then what is it? How do you figure out for a particular patient what their particular safe zone is? 40-15, or looking at the cup under fluoro so half the face is open, isn't going to do it for everybody. So to do that, you need to understand pelvic tilt, understand and the lumbopelvic relationship. One of the easiest ways to do that, which I do on all of my DA hips because it's really quick and it's painless, is preoperative simulation. Preoperative simulation offers automated simulation of implant position. It tells you your effect on leg length and offset. So essentially, you're trialing before you step into the operating room. We all know how delightful it is to trial on a DA on a Honda table and change necks and offsets. A huge pain in the ass. So if I can avoid that, it's great. And what this does is define a safe zone free of implant bone, and bone-bone impingement, which is the genesis of most instability. It also tests the construct of various extremes of motion with common daily activities. Hard to do this on on-table DA hip where you want to check for posterior instability. You're going to flex the leg, stick your finger in there, and try to figure out an impingement. It's going to be hard to do, right? Dislocation is still a problem. Sure, it's more of a problem for the posterior surgeons, but it's not zero. I'm sure each and every one of you has seen one of your hips dislocated. It does happen. It's also one of the most common reasons for revision in modern total hip arthroplasty across the globe. That and infection hasn't gone away. Even though it's less frequent with the DA, if you look at the literature, it's 0.25 to about 2.5%. And interestingly, many are posterior, even done through a DA approach. Very fascinating. This video kind of summarizes the pelvic tilt. If the pelvis tilts backward, you see more of the acetabulum. It accentuates native aneurysm. If it tips forward, it spills out. You get this inlet view and accentuates retroversion. So if the pelvis is fixed in one of these positions, those are the outliers you got to find. You got to catch those because you should do something different with your cup position to avoid impingement. Now, what is that something? I'll try to define that for you. If you look at the studies out there on dislocations, the vast majority of patients that dislocate, even an Abdel study at the bottom at the Mayo Clinic, will argue they're good surgeons and they're careful. 60% of the time, the cups look perfect on x-ray, all within the classic Lewinick safe zone, and they're dislocating. So why on earth is that? There is no universal safe zone, so why do we need to define a target? I'm going to show you that. How do we define a target? How do you say it's 41-22? Or how do you get that number? And lastly, once you know that target, how do you hit it? I don't think any of us with our naked eye can hit 41-17 repetitively. We need some help to do that. This is a patient of mine to show a little science project. She begged me to do bilateral DA hips because she had a very narrow window in her chemotherapy going through cancer treatment, bilateral AV. And I said, sure. Let's do it. Fused pelvis, you can see that's tipped back a bit. Did her hips, x-rays look great. She's had 7 dislocations, 3 on one side, 4 on the other, in every direction, until she finally stopped crawling around on the floor with her grandkids and she stopped dislocating. Just goes to show you that the pelvis and the hips can move in very odd ways if there's fusions, and there's got to be some way to help us figure that out. If you look at the x-ray on the left, the big cat's eyes and the obturator foramina, that pelvis is tipped backward. And if you look on the right, you see an inlet view, that pelvis is tipped forward. If this is associated with a stiff lumbar spine in combination, that means they're fixed in one of these positions of deformity. You need to add a little aneurysm or put less. Now, what does that mean? Add a little aneurysm. How much? How in the hell do you figure that out? You had 5? Can any of us see 4 or 5 degrees aneurysm with our naked eye? Probably not. If you want to take a picture of any slide, this is probably the best one. In the middle is a native 40-20 pelvis, right? And I look to C, you see it's tipped backwards. You see how now you're looking into the cup face, right? So if that pelvis is fixed and you put it in an APP and 40-20, you're actually putting a lot more aneurysm than you think. You could be at risk for posterior impingement and anterior dislocation. I don't do this. This is all over the literature. Larry Dorr started this. Jonathan Vigdorchik took it from there. All these measurements are helpful. I don't have the time. I'd rather take this approach, and the way to do the hip-spine relationship for dummies is to automate it. And I'll show you how we look at this. Now, before I show you how, let's see data. I'm a data guy. I like to see things in paper that I can look at the study and see if there's some sort of evidence that what I'm deciding makes a lot of sense. So does individualizing cup position affect impingement? Doug Dennis did a nice study where he had surgeons template and say, what do you want to put this cup in? 40-15, 40-20, what's your preference? Then they got some modeling and looked for impingement, and they found with CT modeling 2 to 6-fold reduction in impingement versus a standard cup position, just picked as like my favorite 40-15. And also they give you anteversion information on the femur. And bone-on-bone impingement was present in 1 out of 3 cases. That number surprised me, because most of us don't really think about that. Mike Munt did a follow-up study, also said correctly identifying the patient-specific range of functional range of motion in activities of daily living is important. And pelvic tilt matters. You got to look at it. This is a study from Hamilton's group from DA. They found a 0.5 risk of dislocation. The thing that was interesting is that probably a little more than half were posterior and happened during activities of daily living, not some crazy yoga class. So this is the modeling software I use, and this simulates all these crazy positions. And if you look on the right side of the clock, those are all hyperflexion activities. You look at the left side of the clock, these are all hyperextension, external rotation activities. So think about trialing for every possible, you can't do this on a Honda table. If you can take the foot out, contaminate everything, and twist it in every possible direction, I think that'd be really hard. You get these impingement wheels, and if they're all green, I'll show you a video of what they look like, then you know it's good. Here's your feedback you get from the engineer. It's got your size, so for ASC efficiencies, it's great. You know, it's a size 5 and a 54. You don't have to bring the 70 cups or the size 0 femurs. It's quicker. You can get the broach right out of the gate, so you're less broaching, less reaming. It also tells you cup inclination, gives you an immediate effect on leg length and anteversion. Now, you can play with this. You get the report from the engineer, which is great because it saves me a lot of time. It improves efficiencies. I can move the hip center. I can move the femur. If I see something, if I want to tuck my anterior lip of my cup underneath that psoas valley to make sure I don't get psoas irritation, I can tilt it, and it'll immediately give me a impingement analysis, which is really cool. But you can see what the cup looks like. This is what the engineer shows, and you can move it. You can move the femur. You can change version, and the CT will also give you femoral anteversion. We tend to ignore it. Tend to ignore the femur. The femur, I think, in my hands, is a little more variable than the acetabulum. Here you could see a flexion simulation. This patient dropped their phone on the toilet, and then are they going to dislocate out the back? No, they're not. You know you're clear. You're good. And there's an extension activity with a golf swing with a lot of hyperextension external rotation. If you could run that video for me. Click on the bottom left-hand corner, please. There you go. So this is what the screen looks like. Oh, you turned it. That's unique. Hopefully you guys are seeing this too. Anyway, what this does is give you a readout on what I'm doing. I don't know why it turned 90 degrees. That's bizarre. We checked it back there and everything. But anyway, I'm checking the cup. It says 4117. And I'll move my anteversion and inclination a few degrees so I know my range. So if my cup is 40 to 45, I know I'm free of impingement. And on the right side, it shows that the impingement wheels will show you that you're completely clean. And that's all those green. Goes back to vertical. Run this video, see if that flips. I wanted to show you this simulation. There we go. Now that one's correct. All right. I'm getting older. There you can see the golf swing. I don't play with the little animations anymore. All I look for is the right side, right there. If all those little activities of the daily living are in the green zone, you have no impingement. You have nothing you need to change, and that defines the target. It's very cool. And if you want to change anything, the feedback happens immediately. Here you can see what impingement looks like. You see a little red on the back of the liner, a little red on an osteophyte, and a red on the ischium. So now you can add offset, you can add neck length, you can change cup version, you could go to dual mobility. And the minute you do that, it runs your impingement analysis and tell you leg length and offset. So basically trialing without trial. You know what you need to do to get the impingement right and get the leg length right. And if you could run this video, hopefully that stays vertical. This is a case I did recently, and you can see that red in the back. Yeah, this one's staying vertical, good. The red in the back was a posterior inferior osteophyte, and when this patient externally rotated, it would impinge on it. It's a very cool tool, and you could know that you have to go back and find that thing and chip it off with a rongeur. But that would have been hard to see through a DA, way back in the corner there. I wouldn't look for it really unless it was impinging in the OR. Now I know it's going to impinge, I just take it off right out of the gate. So for ASC efficiencies, this is kind of nice. And in the video I'll show you later, hopefully it's vertical. This is the array I use and handle this with navigation, so I can actually hit the target that I've now defined. If you're a data person, I hope you are, there's growing data in the DA world. We're a little bit behind in the posterior world because they have a higher rate of dislocations, and they've got a lot more cases to study. They have probably 6 times our dislocation rate, so they worry about this, and they've shown that navigation robotics significantly improves their stability rate. The data in the DA is still coming out about dislocation, but there are 2 points that need to be made. Number one, there's multiple studies, I think there's 7 or 8 there in the last few years. You're more accurate with cup placement, with navigation or robotics than you are with fluoro or overlay or manual. Duh, no kidding. And significantly less fluoro exposure. That's a really big deal. And it's 5-fold reduction in radiation if you use navigation versus getting all those shots just to try to get a perfect pelvis and match your standing film. Way less fluoro. So for efficiencies, that's a really good thing. You're spending a lot less time trying to get a perfect x-ray. And I'll show you in the video upcoming how I nailed this and how I position where I put my retractors. So now that I told you it's important to define a target, I've shown you how to define the target. Now I'm going to show you how to hit that target. Understand the basics of pelvic tilt and hip-spine interaction. Think about it. Preoperative simulation makes it easy to kind of plug in the tilt, and it tells you what your targets are. Define the target, and trial before the operation will be more efficient. Thank you for your attention.